computer. All right. So we're going to continue with ultrasound applications today. And we're going to try and get into a few more of the more esoteric applications if possible. Because ultrasound is throughout medicine in many different applications, many different guises. How do I get rid of it? Floating, there it is. Okay. So we'll start off where we left off last Tuesday or 2 days ago, where we were looking at echocardiography applications or ultrasound in the heart. And this is a slide describing the sort of general classifications of mitral valve disease. This is a very common condition that people get as they age. You know, one of the big decisions in this disease is, should you have open heart surgery and get a new mitral valve sewn in, right? That's a fairly significant commitment on everybody's part, right?
Oh, yeah.
So you want to get it right. You want to make sure that it's necessary. Nowadays, also in the bioengineering fields, people have come up with minimally invasive mitral valve devices, which are devices that are actually put in without cracking the chest and exposing the heart. You can do it through a port on the patient's chest and just push it in through essentially the apex of the left ventricle and push it up into position. Another opportunity would be to come through the right side, go into the right atrium, go across into the left atrium, and make a very sharp turn and put it down into the mitral valve, right? That's pretty complicated. If you can imagine, if we could see behind the aorta here, these two chambers, the left atrium and the right atrium, are connected by a septal tissue, like they have a common wall. In that septal tissue is a little divot, right? And that divot is something, it's called the foraminal valley, and it closes, in fetal development. It's open for a while, but it's a little sort of divot that you can find and then poke right through it, right? And so planning that route with your implantation device is often guided by ultrasound. So if you have a transesophageal echo probe and you see where your device is, you can get an idea of which direction it's pointing, and then the mechanics of it getting stuck in the divot can be observed directly, say on fluoroscopy, while you're doing the TEE. You can also place an echo probe on a catheter. So this is like a TEE probe shrunken down to the size of a catheter. And then you stick that in the heart chamber and you just look around, right? And you rotate the probe. So that's, intracardiac echocardiography. And that's often used while you're doing this type of interventional procedure. So that's getting from one atrium to the other. And the reason you're going over there is you want to repair this valve, which is the mitral valve. And let's see if that's not working. Whoops. There we go. And so there's a couple of ways it can break, right? One way is these chordae, these basically that are attached to the left ventricle. There's a piece of muscle coming up, and then these tendons come off the muscle and they hold the valve in place, right? They're kind of like the cords on a parachute, right? They hold it there. If one of these snaps, just because from degenerative disease or trauma or something, if it breaks, then the leaflet itself will just flail in space. And you'll actually see that on the echo. You'll see it going, like a flag waving as the blood is passing by. So when the left ventricle is contracting, stuff's supposed to be going out the aorta, it's squirting out here, and this thing will flail. We'll go back and forth. And young people can get this. Another degenerative disease is the entire valve kind of prolapses, and that's what's shown here, is the whole valve surface and the leaflets themselves stretch and the whole thing prolapses back up, and it causes poor coaptation here, and you get a jet through the middle. And then functional mitral regurgitation is when the heart itself goes into heart failure and the left ventricle dilates into a larger left ventricle, and it can actually dilate into this big spherical, ball. And as it gets bigger and bigger, it pulls apart the distance between the opposite sides of the mitral leaflet. It just mechanically pulls them apart. And so then the valve leaflets themselves no longer can make it. They don't coapt anymore. And so that's secondary mitral regurg, secondary to heart failure usually, and expansion and remodeling of the left ventricle. So there's many ways this valve can go down and get broken. When it is broken, obviously a certain fraction of your cardiac output is going back into the left atrium, and it's not perfusing your brain and your muscles and things like that. And so you need to up your cardiac output or up the contraction of the left ventricle in order to maintain the cardiac output to the rest of your body. And the ventricle suffers for that. It can get all hypertrophied. So here's, we've seen this a bunch of times now, but this, if you look at this left ventricle and you had experience, you would say, this left ventricle is in bad shape, okay? Because one, the septum is really thin compared to the total dimension of the ventricle itself. So it's become a thin-walled, large object. There isn't a lot of contraction occurring in the septum itself. You don't see all of these features. This speckle doesn't seem to be coming closer together, right? It just seems to be moving in and out like it's a stiff object that is just translating. It's not straining, right? It's not shortening. And so there are many imaging ways that have been derived from MR, CT, echocardiography to try and measure how much muscle shortening is occurring in that specific location, right? Or in any location. Again, we have some kind of shadow occurring here, so we don't really see this side of the left ventricle that well. Your brain just interpolates what's going on over here by all this stuff that's going on here, right? But they're probably not looking over there because they're mostly looking at this, and that this jet of blue and yellow means that the blood is moving away from the transducer. It's in the wrong direction, right? And so that tells you that there is a jet here. You can measure quantitatively what the peak velocity is of that jet. And you can try and evaluate what the dimension of the orifice left open is and come up with some kind of quantitative numbers to decide when do I put a new valve in, right? What is the threshold for putting in a new valve? If you just have a little leak and it makes a spectacular jet, if not much blood is going back the wrong way, then maybe you just leave it alone, right? You can hear it with a stethoscope. That's probably how the person wound up on your echo machine, but it's not going to do them in, right? So better left alone. So now we've got a sliding scale, right? And you have to say, okay, at what point does it become severe enough that I put a new valve in? Do you wait until the person presents at the hospital with symptoms that they can no longer deal with, right? They really don't want to live on just the ground floor of their house. They would like to go upstairs. And do you wait till it gets that severe, etc. So symptoms are usually a late and sign of quite severe disease, right? So usually you can get ahead of the curve by looking at data like this. So that's the mitral valve. The first valve that was really repaired in great numbers was the aortic valve, because aortic stenosis or a bad aortic valve turns out to produce symptoms very quickly, right? And those symptoms are quite severe. And if the valve itself, as we'll see, if it becomes stiff and stenotic, it produces left ventricular hypertrophy pretty quickly too. In a healthy valve, and so you guys are all in your 20s or whatever, and that, you know, your valve is nice, smooth tissue, there's nothing on there, there's no calcium or anything on there, and it's just coacting really nicely. And when your heart ejects blood, it opens way up, and so there's no resistance. So all the heart's doing is pumping blood against the distal resistance in your whole body, not against this valve, right? And so you have this normal looking heart. If you do a lot of exercise, you become a rower, or you become a marathon runner, or you become somebody who does a ton of exercise, you can get a hypertrophied left ventricle, but that's healthy hypertrophy, right? It's not disease hypertrophy. However, as you get older, if your valve gets it's odd. Like when you look at these valves, they become embedded with chunks of calcium, right? And so they themselves mechanically become stiff. The valve leaflet itself becomes stiff, becomes deformed in shape. And so what can happen is the valve no longer closes properly because of this deformation in shape. And when the left ventricle produces pressure and it tries to open, it no longer opens properly. So it opens in some weird configuration, which is not fully open. And so you still have, you know, when you have your hose, you haven't opened the hose up the whole way, right? You've still got a stenotic thing there. And so your heart's working against this when it's pumping, and it's basically, you know, getting blood pushed back in to the left ventricle from the aorta itself. So that blood is not making it downstream, it's just flowing backwards into the left ventricle, which is not good. So you have to do X number of heartbeats to compensate for that. You can, if you just type aortic valve stenosis in Google, there are like 9,000 papers that are good papers on this, and videos on how you treat it and everything. So the big interest here is like, we can replace this valve, and millions of people have had this valve replaced surgically. So they crack the chest, expose the root of the aorta, cut this valve out, right? And then stick a new valve, a mechanical valve in there, and you sew it down really well, and then put the aorta back on top, right? And you got a new valve. This is just like night and day. It's fantastic, right? This is done a lot. You know, you're supposed to rest afterwards because you don't want the sutures to rip or anything like that, right? You just let it all settle down. But then you're good to go pretty well. And they last, you know, 20 years, 30 years, these surgical valves, right? So it's, as heart surgeons, as jobs that heart surgeons do, this is a pretty good job, right? Because, you know, you're like a human mechanic, like repairing this thing, and you just do it day after day, and everybody who walks out of your clinic is way better, you know, so it's a good job that way. The bad part about cracking somebody's chest, obviously, is they have to get over that itself, right? So when you crack somebody's chest, there's a lot of recovery period for the surgery. You have to put them under anesthesia, deep anesthesia, which carries its own risks, etc. Right? So people have come up with new ways of putting valves in here. Transarterial valve replacement, or TAVR, where you load on a fairly large catheter a compressed valve, and you put that into their artery in their leg, say, you know, in their femoral artery, and you run it up their aorta over the arch, and you bring it to this location here, and you cross the valve with your catheter, and then you pull the catheter back and leave in place a valve. So it's done completely without cracking their chest, right? And over the last 10 years, the numbers of procedures like this are probably increasing by a factor of 3 every year, right? So it's exponential growth in this procedure. It started out with just severe disease, then it moved to less severe disease, and now you're doing it in 50-year-olds, right? So that's called TAVR, big business for Medtronic and Boston Scientific and people like that, because it's a huge thing, right? We looked at this at using echocardiography in aortic regurgitation briefly. And when you look at the velocity spectrum right down the aorta, you can see the peak velocities is ejecting, and then the decay away of the velocity that is the regurg. Here's, if you then go up to the descending aorta, so this is away from the heart now, we're going around the other side and we're looking at the patient's back, right? So far away from the heart, and you get a velocity profile in the descending aorta. Obviously it goes really fast, meters per second while it's being ejected, and then it should just stop, right? And people like this, you get this blush of negative velocity of the whole thing moving back towards the heart, depending on how much blood is going back into the heart, right? And so you can measure, this is one of those B mode scans versus time. So it's like an M mode Doppler. And if you do that like right down the middle here, you can see the peak velocity of the ejection and then this long decay of negative velocity going back to the heart. So there's lots you can measure, right? Is the message. And so this is a really good paper that came out a couple of years ago, and where this team here, specifically this guy, Joan Bax, has been doing echo in heart failure patients for, I don't know, 30 years or something. He knows this space and application really well. So the question is, what should you measure in these patients to determine that they should get a prosthetic valve now, right, versus later? And is there a way to determine, prognosticate, or who's gonna do better than, with this therapy? Excuse me. But the main question is, when do you put the darn valve in? If this disease is discovered, say I could have a small amount of regurg in my aortic valve, and I'm at that age where that can happen, and it looks like I'm headed down that path, I'm eventually gonna have a valve replacement. When do you do it, right? So you can measure with echocardiography. This is why we're here. We're doing applications of echo, a lot of things, right? And the things that you're measuring are not imaging things, right? They are physiological things. So those things, if you can measure them accurately in thousands of people, those things are not going to change over time. As imaging gets better, right, the only thing that changes is your accuracy of your estimates of that physiology, not the, any fundamental thing that all of a sudden doesn't matter anymore because this machine has been replaced with a better one, right? So you really want to, design, when you're engineering these machines, you're making better and better pictures, but you always are focused on what is the physiology that I can measure with superb accuracy and reproducibility, such that that can be used in making decisions, right? And so here is a set of patients. Each one of these is a different patient. And with all of their experience, these echocardiographers came up with a way to stage patients, like put a number on the patient on how severe this disease is based on the physiology that they get out of their echo machine, right? And as we've said before with echo, having a really good physician look at your case is probably the best thing, because that person has all of these stages programmed in their head. They don't know how they're doing it, but they know, oh, that person's really severe, that person's okay, right? So how do you quantify it? These guys came up with a mechanism by which they make measurements to get to these stages, right? And so if you look and you say there's no cardiac damage to the heart, the valve might have some regurgitant jets, right? But the heart seems to look normal otherwise. So it's just pumping away, right? So that's stage 0. Stage 1, they measure a few parameters and make cutoffs for those parameters, in that the LV mass index has become greater than 115 grams per meter squared, where a meter squared is the surface area of a person. And that's usually estimated using their height and weight, right? To get this normalization factor, because in big people, hearts are bigger, right? And little people, hearts are smaller. So how much mass should you have in your LV? And if it's greater than this threshold, they say, okay, we're pushing that patient up to stage 1. They no longer have a normal left ventricle. The ejection fraction, well, we all know what that is, right? It's the volume that you start with at diastole, right? Minus the volume that you end with it consistently. So the amount of blood ejected divided by the amount you started in diastole. So that's what percentage of blood went out. If less than 50%, you wind up in this bucket. And then there's this one, E to E prime ratio, which requires that you measure velocities. And so the E to E prime ratio is the ratio of the velocity of the blood going through the mitral valve at its peak, right, divided by the velocity of the valve ring moving upwards, right? So you've got mechanics of the valve ring moving up, and you've got the velocity of the blood moving down. And it turns out, if the mechanics of the valve ring moving up gets reduced, i.e. it's kind of slows down, right? And the velocity pumping into the ventricle, into the LV, right? This is filling. If that's high, because there's a high pressure in the left atrium, that's indicative of a sick person, right? So when this ratio gets here, you're in bad shape, or you're getting into worse shape, right? So these are all things that are physiology measurements, but they're made on imaging features, okay? It's the precision of measuring the velocity with Doppler, right? It's the precision of defining where the mitral valve plane is and how it moves over time, right? So that's all the engineering stuff that when you're building your scanner, you're trying to build a phantom to test how accurately can I tell you that this velocity is moving. And then it all boils down to coming up with some kind of physiology measurement in a person. And the other thing is that if you go into this field, you can build a phantom, which is like a mechanical device that simulates what you're going to see in a person. And that way you can scan it over and over and over, and you know the underlying truth to the stuff you're measuring, so you can measure your accuracy. But what happens with phantoms is you just engineer until you get a really accurate answer on that phantom. And then you take it to a person, and it may not generalize, right? So phantoms are good to understand whether or not your method is reasonable. It doesn't have some big problem, right? And then you optimize usually to get to the right answer. But the fact that you're tweaking your technique to get to that single instance of this, physiological function usually doesn't generalize well. So you have to try it in people,
How do you make phantoms for ultrasound? Because like if you measure something, you have something moving, like phantoms in general stationary.
Right. So the question is, how do you make a phantom that's realistic for ultrasound, where you need the tissue to be moving at a specific velocity and a specific reproducibility and stuff like that? Well, there's many, many people that have built certain phantoms, and agar gel or some kind of gel is a that doesn't dissolve is a really good place to start. And then you pin surfaces on that and you rotate them, you compress them, you put little markers in there that could be things that generate the speckle pattern. And so you test your resolution of how the speckle is coming together, et cetera. So that is, in fact, it's not a cottage industry, it's actually a real industry, and that is making these phantoms. And so if you go to any of these conferences, whether it's the echocardiography conference or the Radiological Society of North America or AHA or whatever, there will be booths there of people who make these phantoms. And usually you pay about anywhere from 10 grand to 100 grand, depending on how complicated the phantom is. And a lot of them have a computer that drives velocities through tubes of, different fluids and things like that. So, and some people do it for their PhD. They come up with the most fantastic phantom, in the history of that imaging modality. So that's not uncommon in an engineering lab for somebody to do that. So then we get to stage 2, and here we have left atrial or mitral damage, right? So we're looking at the left atrium now. Remember, this is aortic valve stenosis. And now we're looking at the, mitral valve and saying, is the mitral valve involved with this? If there's, mitral valve abnormalities, then this patient gets put into another territory. And then stage 3 and 4, when they're really sick, you get pulmonary vascular or tricuspid damage. So now we've moved to the right side of the heart. This is the aorta is failing, right? Because it's stenotic. So it's a little tiny hole and the thing's trying to push. And now over the years, you look and say, well, what's disintegrating here? The right side of the heart is disintegrating because maybe I have huge pulmonary pressures, right, to push against. So, here, really high pulmonary pressure is a bad sign. If you have tricuspid regurgitation, that's on the right side, then it's a really bad sign. And then, so that's the right atrium and valve. And then when the right ventricle itself starts to go down, starts to fade, and this is a thing called TAPSE, which is basically just the total amount of motion, if we look here at this valve plane, of this thing going up and down. Okay, that valve plane moving up and down. If that stops moving up and down, then you're in really bad shape. Then your right ventricle is failing. So when you look at them without looking at the results, you look and go, well, how would you guess that these are the things you should measure, right, to classify these patients? And you couldn't. There's no sort of a priori way of guessing other than retrospectively, when you look at it, you say, basically, if you're getting sicker farther and farther away from the primary thing we're looking at, that's a bad sign, right? So you want to intervene before we start seeing this domino effect of other things going down or going bad. But otherwise, there's no real sort of first principles derivation of what these parameters should be. I just put the slide in. You guys, as a record, there's because we didn't talk about this thing, this E to E prime ratio, and it's used quite a bit in echocardiography. And here's a definition of what it is, and here's an article that reviews a whole bunch of stuff on that. So here's all the stuff they measure with echo, right? That's a lot of stuff, right? A lot of business to go through in each case. They start out with 1,200 basically of these patients who definitely have aortic valve stenosis, right? And then using this staging criteria that we just looked at, those patients are broken into these groups, right? And then you look and ask, how does each group fare over time, right? And then you can look at the different indices themselves and ask, for this, I've got 5 buckets. Is each bucket different than its neighboring bucket, or is there a relationship between this index, say LV mass index? Is there a linear relationship between these stages and that parameter, right? So it's very simple regression analysis where you say, okay, here's my physiology parameter. I've got now 5 classes of patients. Do I have a strong relationship between that parameter and my class of patients, right? You can see where this is going, right? This is just machine learning done by people, right? So if you measured all of these things and then stuck it into a support vector machine, it would come up with a formula for all these things that divided them into these groups, right? Because these are your outcomes that now you have to originally come up with these buckets to do that in machine learning, right? So anyway, as you can see, there's a p-value, a really good p-value for everything, right? That's on this list, like septal wall thickness. You look at that, et cetera, et cetera. And then this, with those categories, here's our 5 buckets of patients. These are the really sick people. These are the not so sick people. Remember, all of them have aortic valve stenosis though, right? And you're deciding, do I repair it or not? And then you do a survival curve, right? One's called Kaplan-Meier survival curve. But anyway, over 5 years, we follow these patients and see what happens to them. The vast majority of these folks had a new valve put in, right? At say between when this was taken and then a year, somewhere in there, and this is how they did, right? So basically you can bucket these two together essentially and say, well, you got about a 1 in 4 chance of dying, right, in the next 5 years. And you bucket these two together up here, and you got a greater than 50-50 chance of dying, right? So this is done over and over again with all sorts of medical tests, diagnostic tests, and this prognostication as to which of these patients is truly severe. What features truly make this patient, severe, and that they have a much higher probability of dying in the near future? This is the kind of question. You can use other things like rehospitalization, heart attack, all these secondary outcomes, but all-cause death is often used because it is fairly binary, and you just look it up, right? I mean, if you have the person's social security number, you can just look it up, right? And so there's no errors in here about putting people in the wrong bucket. They either survived or they didn't. So it's often used. So here you've got, basically what I would say 3 categories, right? These folks somewhere in the middle, and these folks, right? And this can give you an indication, like if you're looking at somebody and they're down here at stage 0, you can tell them what their odds are, right, of waiting, right? If they wait until they're at stage 3 or 4, it's not a good thing. You should probably get in there before these other things start falling down. And again, here's some, like, nowadays they have all these amazing, I'll show you some other images of 3D pictures of valves and stuff like that. So an aortic valve, right, opening and then remaining really nicely closed here. This is it. Let's go back to Arrow. One of the big things that's occurred in terms of the aesthetics of medical imaging, of 3D medical imaging, is this thing called cinematic volume rendering, where very advanced material composition, reflexivity, and lighting models are used to make something look like a plasticine model. It's fantastic. And so this is a valve you know, being visualized in 4D with this cinematic volume rendering. I think this will play. Yeah, there you go. You can change the lighting model to behind it. This, let me get to pause here. This, oh, shites, sorry. Should be able to pause that video, right? Okay, here is a feature now on a number of ultrasound machines where if you have a CT, you can read the CT into the ultrasound machine, right? And you put landmarks at, so this is the valve cusps, right? You can put these dots here, right? At certain, so this is the anterior portion of the mitral valve, and here's the other 2 points on the mitral valve. And that'll line up your echo with the CT. And so just the way we looked at PET on top of CT and SPECT on top of CT, you can now do that with echo on top of CT, which, you know, for certain applications be useful, but I right now I can't tell you which one is the most useful. I think planning, if you were planning an implant, right, and you wanted to know precisely the dimensions of everything, and then in real time you had your echo on top of it, so you could see where things were with respect to the CT, would be advantageous, right? And so here is using echocardiography, using the raw data itself to come up with sizing for a valve that you're going to implant. And so Boston Scientific or Medtronic, who's ever making this valve, they sell it in many sizes, right? There's usually about 5 different sizes. And depending on how big your mitral valve is, you get the right size and everything goes well, right? So part of the surgical planning is like make these measurements and come up with it to pick the right valve off the shelf, because they're expensive, right? They're like 10 grand each or something. You don't want to open it and start sewing and go, oh, that's take it out and get the next one. So that's that. And then here's, remember we were looking at these velocity, these Doppler spectra, excuse me, down this dotted line down here, right through the aorta, and you get these beautiful velocity spectra that on most machines now, they make these automatic segmentations of this data so that you can measure peaks, the derivatives of these curves, et cetera, and get mechanical information, which is what you'd want to do if you were trying to, fill out that enormous table of people to figure out what stage they're at for aortic stenosis. So we'll look also, so that's aortic stenosis. Any questions about that? Does anyone have friends or parents or something that has an aortic valve put in? No. I had profs, colleagues, stuff, a bunch of people have had them. Yes?
I had a cork of my aorta.
Oh, is that right?
Yeah, they had to go in and snip it and stitch it back together, and then I had a catheter operation to blow it up.
Oh, okay.
Later in my life, yeah.
Did they put a stent in there, or did they surgically repair it?
So they surgically repaired it when I was a kid, like very young, and then they were going to put a stent in because the scar tissue wasn't growing. And then I guess the scar tissue broke correctly, and they didn't need a stent. Oh,
that's terrific.
Yeah.
Human bodies are amazing, right? You can do incredible things and they adapt, to what's going on. There's one of the issues of waiting for symptoms is the human body is really good at compensating for stuff. And so by the time you get symptoms, it's usually pretty severe. So, well, that's great. So in terms of, the famous people had these aortas put in, like Arnold Schwarzenegger had one. And he didn't listen to his doctor's advice and he got on an exercise bike and like got his heart rate really high, and then boom, kind of blew some of the stitches. So they had to go back in and give him another one. You know, it's like, oh, come on. So that time I think he waited. Yeah. Then who else? But now these TAVR operations, if you're really sick and open heart surgery doesn't look like it's a great thing for you, you can get a new valve, right, with a TAVR operation, which is great. CT is principally used to plan for that. And so you get a very high resolution CT, actually from the patient's groin all the way up, because you want to see the pathway for the catheter. And then you size exactly the root of the aorta, you know, that of the valve that's going to go in. And, you know, and then it's basically done under fluoro at that point, fluoro and TEE, and they position it and then open the valve. Oftentimes, if there's a lot of calcium on the valve itself and on the wall over here, it's not a huge problem. And in fact, can be advantageous in that when you blow up the new valve, it has something to grip onto. And so you have this stuff that you just push it off to the side, right? And it sits there. Okay. So this is transthoracic echocardiography, i.e. on the chest, right, of someone with pulmonary hypertension. This is a normal person, right, where we see the left ventricle. Remember that this is the septal wall, opposite wall, aorta here that looks wide open, mitral, and the left atrium here. And you see a small section of the right ventricle here, right, because it's wrapping around the other side. So you just see one cut through. When you look at somebody with pulmonary hypertension, their right ventricle is going to look like this, right? So that means the right ventricle itself has been dilated. And if you looked at this on short axis, it looks like the septum has been flattened, right? So now the left ventricle is a crescent, or basically a half moon, and the right ventricle is pushing against the septum to flatten it out. And it's pretty darn obvious when it occurs. Now, the issue with echocardiography and measuring the right ventricle is it's very difficult to get a view in which you kind of get a global feeling of how the right ventricle is doing, because the right ventricle is wrapped around, you know, the sort of right anterior wall of the heart, and has a highly variable shape, right? And so it's hard to get good echo pictures of the whole volume, right? So normally for right ventricular anatomy and function, it's better to use magnetic resonance or CT, but nobody uses CT. But so you would go to MR usually, or MRI. So breast ultrasound is used a lot if somebody has a positive mammogram, right? Or they have a mass that they can just feel it, right? Mechanically, you can feel, hey, there feels like there's something stiff. It's like a lump. And so obviously it has different material properties, right? Because it feels stiff to compression. So it's going to generate echocardiographical signal. And these lesions in the breast usually look like this, in that they have a dark, it's called hypoechoic mass, right? And if you have a lesion that looks like this, that's usually a good sign, because you see how smooth the borders are. That is usually a benign growth, or sometimes a cyst, right, in the breast. And now this example, it says repeat US scanning through the entire mass by the radiologist demonstrates suspicious blah, blah, blah. Why they throw the echo tech under the bus, I don't know. It's like, oh, when the radiologists took the probe, they found this. But anyway, forget about that. In a different plane, when we're scanning through that, we're seeing that we have this sort of, as they call it, microlobulated margins, right? I've never heard that word before, but anyway. So it's these jagged edge margins. That's not a good sign. So that means that it's not a sort of smoothly contained mass. It's shooting out some tissue. So that would say, oh, okay, we're gonna biopsy this thing, and we'll see what kind of cell it is. Because histology now, if you suck these cells out, they are very familiar with all the different types of breast cancer, and they'll be able usually to classify it, right? Yeah, sure.
What type of avoid if it is bigger than
That's a great question. So the question is, why does it show up as a dark spot, right? Right? Why isn't it a bright spot, right? And for whatever reason, the internal structure of the tissue here is obviously a lot more homogeneous than the internal structure of this tissue, right? So in some respects, it doesn't matter if it's modulus means it's stiffer. If it's smooth and there's no features inside it, then you won't get echoes inside it, right? You'll have an echo off the surface, and then it'll just be a smooth transition until you get to this transition again, right? So that's why it looks dark. That's why the left ventricle with blood in it looks dark, right? Unless you put microbubbles in it. You can inject contrast and see if blood goes into this thing. And you can also do Doppler and see if blood flow is flowing inside this thing. If it's a cyst, there won't be blood flow in it, right? If it's a tumor, there likely will be. And also if there's a tumor, there's often a lot of blood flow around it coming into it. So they sometimes do Doppler with it too. Here, palpable right breast mass. So this tissue is obviously stiffer, right? However, if you didn't have an arrow and two cursors here, you know, for those of us who don't have experience reading these things, you wouldn't see that. You know, I certainly wouldn't see that. So it takes a lot of experience and the fact that you're there with your transducer in your hand and the breast is right there, so you can palpate the mass itself, right? You can, you know, look and say, oh, okay, there's something here, bang. And then take this picture and you know what it is, right? Now this is at 12.5 megahertz ultrasound. We're not going very deep here, right? So we can crank the frequency up, get a higher spatial resolution picture, and here's the mass at 17.5 megahertz, right? So you get much better border delineation here and size of the mass and stuff. So to me, this is much easier to see than this, right? And so that's the effect of optimizing your frequency for the application. When the application's at the surface or not too deep, you can, because as you can see, it falls, the resolution falls away pretty fast as we get down into here. This is an example of that mode of ultrasound that we discussed called harmonic imaging, where instead of making the picture from the primary frequency that's reflected, you Fourier transform the data coming back and you look at a higher frequency that is reflected. And this, it doesn't say, I think, which to the target. Harmonic, it just says harmonic. So it could be the first harmonic, but it certainly makes a difference in this, for the contrast to noise of this feature, right? And so again, this is just a button, right, on your echo machine. And so you can go and just try harmonic and see what comes out, right? Here we have, again, a hypoechoic mass here. So this looks suspicious, right? And then what's done here is you actually fire a pulse through the tissue a mechanical pulse through the tissue such that it sets up a wave in the tissue, and you measure the shear modulus of the tissue as that wave is going by. So, we'll see some slides on this in a minute. And then this highlight here says, oh yeah, this thing here is quite stiff compared to the surrounding tissue. And therefore it stands out as probably a cancer, right? Oh, here you go. So I think somebody asked a question a few lectures ago about, hey, what would happen if you shot ultrasound in with one transducer and measured it with the other? Well, this is what happens. So you can vibrate the tissue, right, in a transverse direction, and then measure how it affects the ultrasound coming back pre and post that vibration. And in general, it will give you something that's proportional to the ability of that tissue to strain, right? And so the shear modulus for one wave and the bulk modulus in a longitudinal wave. So first, let's take a look at these two things. What is a shear wave? A shear wave is if I have a connected set of particles, right? And say I have a 3D array of connected particles, and I got little springs between each ball. And I take the one face of that large array and I move it up and down. A wave will move in, say, the X direction longitudinally, and of particles going up and down, right? That's a shear wave. And so when you're surfing a shear wave, right? Because it's moving from the ocean towards the beach, but it's moving up and down, the water molecules. And so a shear wave has a certain propagation speed, and it's proportional to the density of the material, and 1 over the density actually, and the shear modulus, right, of that material. And so it's how tightly connected is it for doing that deformation, right? And those waves actually travel slowly, 1 to 10 meters per second, a shear wave, right, in tissue, right? So say liver or something like that. Whereas we know longitudinal waves, I mean, we did some problems on this, right? They're up in the 1500 meters per second, right? When I compress and see how fast that compression races through the sample. So actually doing strain imaging with these waves is very hard, right? Because everything's happening a little too fast, right? Here, you can measure a difference in the shear modulus between one tissue and another if you have this wave moving through and your ultrasound is perpendicular to that, right? And you measure that displacement. And the way you measure that displacement is you have an echo, right? This is just the ultrasound echo, the raw signal coming back, and it's been literally displaced, right, after the strain has been applied. So there are many ways of doing this, in the sense that there are many ways of applying the strain to the tissue, right? One is just take ultrasonography, and the expanding vessels, will deform the tissue. Another way is I'll take my ultrasound transducer and I'll continuously acquire my images while I press down on the tissue. So say I have it on the patient's liver, and I go, ugh, and I push it down, so I squash the liver, right? And then you take those difference images between the pre and the squashed liver. If you have a mass in there that's stiff, the tissue around it squishes more than the mass, right? And so it stands out, right? And one of the things is the speed of the propagation of the shear wave or a longitudinal wave that is proportional, as we see, to that shear modulus. And so you just measure the speed of the sound in there, and you get this contrast, right? So then you can have probes that themselves create shear waves by some kind of mechanical vibration. You can have an orthogonal probe that puts a ping into the tissue and you measure it while that ping is rolling by. Many, many different ways of skinning this cat. These are the modes. This is basically longitudinal strain in 1D, and the amount, the Young's modulus is the ratio of the stress required to produce that amount of strain, right? In that direction. So how much force do I need to apply to this face in order to stretch this thing out by that much, right? Shear modulus, it's basically how does the thing tip, side to side. And so when we were taking our object, in this case, in this diagram, they're displacing the bottom and it's moving up towards the top, right? So, and then the bulk modulus is just compression, right? And so here, this is a nice review article of ultrasound shear wave imaging or strain imaging. And it goes through all of the different methods of doing this. And so here, this was the first one used. You just push the darn transducer down, right? And it makes sense. I mean, if you've ever gone to the doctor for a checkup, what's one of the things they do? It's like you lie on a table and they like just take their finger and push around and see if you're all soft, right? If they go, whoop, oh, there's something really hard there, then that's a problem, right? So this is a much more advanced way of doing that push and see what occurs, right? You can see it deeper. And so every manufacturer has their own spin on this and one way to do it. Here's some examples with, so here's another hyperechoic breast lesion, right? And this shows the essentially stiffer material in red. And it's a new technique because when you go through the clinical examples, sometimes the color bar is inverted, right? So nobody's come up with a standard yet. So, you can measure these pressures here. Here, this is that previous example we were looking at in liver, right? Where a shear wave is coming through this liver and you're measuring basically the speed of that shear wave is this color here. And because the velocity and the modulus, they're totally connected. So here it's like 1.7 meters per second. And this, I think it's this, they didn't have a liver image in this big review article. Although they talk, it seems to be the primary application for this. And the reason is that your liver tends to, as you get older, you drink a lot or you get sick, it tends to fibrose. You get a lot of fibrotic tissue in the liver and it gets stiffer, right? And so measuring this stiffness is like something you should do on a physical, probably. Just saying, oh, how stiff is your liver? Is it in the normal range? And so if you could do it just like this, it was great. The issue is that they're still in the phase of this technology where there's a lot of variability in the numbers that are coming out. And so this entire article is about establishing within what variability is reasonable for making this measurement, right? It's an interesting look at a technology where they're at this phase where they're trying to establish. We've got all of these commercial scanners now that are producing different numbers. What is a reasonable, who should you believe kind of thing? So the two primary applications for elastography, so it's often called elastography or strain imaging, is diffuse liver disease, which is probably in healthcare, one of the most important, and in breast lesions, right? And sort of confirming that there's a lesion there. And we will see in an example just in a minute, since you see that the breast lesion is there, you can then absolutely and confidently direct a biopsy needle to the right location, right? And, or if you're going to take that thing out surgically, and it's a small lesion that you can just do a partial mastectomy, and so you just want to take the tumor out and leave no tumor in there, you can put a marker wire. And because when you're a surgeon and you're looking at the tissue, it looks the same, right? Visually, it just looks the same. It's not like a blue thing is the cancer. And so you have to know, like, what should I cut out? And so you can mark it. So we can go to that application now. Let me see what time we're at. Is there any questions on this so far? Yeah.
Why is shear wave imaging always supplied from different and price? I think for muscle is also I think muscle also has this different biomechanics property. Why is not finding less over?
So the question is, why is ultrasound elastography not used in muscle imaging often? Okay, I think there you'd have to ask, like, what is the disease and what is the process that you would diagnose with muscle imaging, right? And so if there is something like Duchenne's disease or something that has a component in which the muscle itself becomes fibrotic or changes its shear velocity, then you could use it to classify those patients. And I don't know of one, yeah. But it could be used, I mean, because it's right there, right? So. Okay, so we're gonna look at ultrasound guided biopsies and ultrasound guided wire placement for surgical planning. And it's really simple, right? The way it's done, but it's hugely, really effective. And that is usually a tech or the physician has the ultrasound transducer in one hand, is interactively looking at the tumor. So it has she has the target in place. And then you just push the needle and you look for the needle in the ultrasound, right? And get the right spot. I think. Yeah, okay, so this is what she's looking at on the screen, right? Tumor comes into view here. And you look how dynamic stuff is underneath, right? And so small changes in the scan plane will change what's going on here. Okay, in this case, she is inserting this needle and she's watching that. So this, you don't want to practice this a bunch on a phantom before you did this, right? Because look how the tissue deforms, for one thing, as we go back and watch this. Like, as she's advancing the needle, look how much deformation is in the tissue, right? So there's a lot of skill in your ability with needle manipulation in a soft, compliant object. And you've got the transducer that you've got to keep on plane, right? And hit the target, right? So it's a particularly human thing, I think teaching a machine to do it would be quite difficult, right? Because of the underlying motion and everything that's going. And so that leaves this needle in place here, and then a wire is placed inside the shaft of the needle right to the depth that the tumor was at, and then you hold the wire and pull the needle back, and now the only thing left in there is a wire, and that wire goes right through the tumor, right? And so here it is, right? And the surgeon, when they go in to resect it, they resect, I don't know, a couple of square centimeters or something, and you can confirm that the tumor and the wire and everything came out the right spot by just x-raying what was resected, right? So that's ultrasound to just nail where the place you should go in there if you're doing that kind of surgery. And then this device, and there are hundreds of these on the market now, made by many different companies. And you can imagine that a needle biopsy device, because it's kind of low tech, the barrier to entry to this business is not terribly high, right? I mean, if you can make a really nice cannula, and you have these markers on here that appear in ultrasound and X-ray. You have the mechanics of a trigger system that when you get to the target, you just pull the trigger and it takes out a sample without any delay, so that you're not moving around. So also probably the IP is probably pretty old, right? So you can make one of these devices and not infringe on anybody's patents because they're all 50 years old, right? So anyway, you can go online and there's tons of these companies selling these things. And so you have a outer cannula or needle part. Inside there, you have this stylet, which is a really sharp thing. It has a little scoop on the front. And what's going to happen is we're going to move this right into the location, so that we know this will advance about 2 centimeters or a centimeter. You set it out in front, and then it'll suck a chunk of tissue back into the cannula, and you go and look at the cells, right? And so here, do I have a, oh yeah, okay, good. So here's the device itself. You can see here's the markers, right? Wait a minute, right? So this doesn't look like the one we just looked at. It has its trigger, looks like a thumb trigger here. You have your transducer here along. You want obviously the shaft, of the cannula to be aligned with the plane of the ultrasound, right? It's going to come in and out of plane pretty easily. And then we'll watch as she just gets herself in position. You see the needle here, right? And then this is the tumor still in the plane, and she's going to push, bunk, there it goes. She pushed that, and now she'll pull back tissue out of that tumor. So that's so there's an amount of tissue there that goes to pathology, and you just find out what kind of cell you're dealing with. There's also a simpler way to do this, which is called a fine needle biopsy, in which you just take a really fine needle and suck cells into the needle and then pull it back. So, but these things are used a lot. Okay, any questions about that? Yeah, okay, we got about 10 minutes. So the next thing we'll look at is these intravascular ultrasound catheters. And these are catheters that are, a millimeter, couple of millimeters in diameter. You put them, or even less, you put them into an artery, and you can put them in the radial artery or in the femoral artery, move them all the way up to the coronary, and then push them down the coronary and take a look at what kind of lesions you're dealing with in a coronary artery. And so this is on YouTube. This guy does a great job of explaining this field. And so here's 2 types of these catheters. One is you essentially have a fixed phased array of transducers that are on a cylindrical orientation, and you'll make pictures. You'll just go round and round that cylindrical orientation. And this is a more original way this was done, is that a motor just spins an inner drive shaft upon which the ultrasound transducer is sitting, and that thing spins around and just produces images as it's spinning around. And so you see these circular pictures around the catheter, and then there's a whole bunch of different types of these. This has been a field of investigation for many, many years. Like Paul Yock, who's a guy at Stanford, started a company 35 years ago on this, I think, something like that. So it's a fairly mature technology at this point. However, it's expensive to pull one of these down and take an image with it, and then you throw it away, right? And so you really have to ask yourself, do I really need that much information about this lesion, right? So here's basically what the pictures look like. This is obviously they're ultrasound, so they're going to come out in real time. So we have adventitia, this dark rim here of non-echoic media, and then the intima. And lesions usually occur in this around this boundary here. And then this is where the catheter is itself. And this is blood here, right? And I think these are, yeah, there we go. So here's one of the phased arrays, and look at the frequency of this thing. It's not 8 megahertz, it's 40 megahertz, right? Because all we're going is a few millimeters into the vessel wall, right? So we're at a very high frequency. I'm gonna restart it. This is the phased array version. You can see the sort of nature of the resolution and the noise as it's moving around in the vessel. Here's a rotational version at 40 to 45 megahertz. Again, here's the vessel wall out here. And then this is at 60 megahertz, which, as you can see, the spatial resolution starts to get really fantastic, right? It's almost like OCT, optical coherence tomography, where you have the intima all there. So that's pretty cool. And then this is some data on what happens, with all these different technologies. If you have a true diameter, true known diameter, say of 3 millimeters, OCT nails it at 3 millimeters. That's probably the ground truth, right? IVUS overestimates its size a little bit. Angiography underestimates its size a little bit. And then, I don't know what this visual estimate is. Oh, this is probably visual estimate of angiography, right? Is highly variable, right? So, and some of the features that you can pick up with these little transducers, this stuff is soft plaque, right? So you can see that the lumen of the vessel is pretty small compared to the size of the transducer at this point, right? Whereas the lumen should be something like this. In this vessel, it's pretty small, and all this junk in here is plaque, right? And it's soft plaque because it doesn't have really shiny bits of calcium. So calcium would cause a huge echo, and it causes a shadow behind that echo. And so there doesn't look to be any calcium here. It's just all a soft plaque. Here, this really bright stuff out here is some fibrotic tissue, which is just outside the intima. And it's fibrotic because you can still see through it, right? It's not crystalline calcified tissue. This is what calcium looks like. And you can see I have this arc here of calcium, and here's my lumen. This looks like soft plaque right here, blood over here, and then calcium, and then behind it is this dark shadow. So it's calcium and it's not fibrosis. Here you've got mixed calcium all over the place. You see these shadows are cast about, plus these bright things here. So you got calcium at all different depths in this lesion. We have an arc of high calcium right in the intima, and then I don't know what these are out here, if they're artifacts or true calcium beyond this one, I don't know, but I think these little wisps here are that echogenic artifact, that the bouncing from the calcium back to the transducer, back to the calcium, back to the transducer. And here's some superficial, that's a lot of calcium on the outside of this. The whole thing's dark around it, right? So to understand what your calcium situation is it worth doing this? That's what you have to ask yourself. Like, if I'm going to treat this vessel and I really, am I going to put a stent in it? Do I want to know what the calcium content is? Do I need to do this first, right? You can see calcium a little bit on coronary angiography. It's not great. It's kind of faded. On CT, it's fantastic. You can see where the calcium is. So I'm not sure. I think I'd rather have a CT than this. Although you're in the cath lab anyway, right? When they put one of these down, it's probably another few $1,000s for your case. And so here's some of the reasons why you want to put that thing in. Lesion assessment, which is what we just talked about, in determining, how big the lesion is very precisely so that you can pick the right length of stent if you're going to put a stent in it. How much pressure is going to be required to open my stent in the balloon, given that amount of calcium, right? If you have this huge concentric calcium, then you realize, okay, I'm probably going to have to pump my balloon that's expanding my stent up to a very high pressure in order to crack that calcium and put that thing in there. And then after you've put in your stent, you can push the catheter back in there and see how things are going, right? Here, things aren't going well in that the stent has not been blown up to its full size, right? And so there's a gap here. So you don't have stent apposition. So you want to go back in and blow that thing up, right? Under expansion, again, we just, the whole vessel is still kind of closed, right? So you really haven't done the patient many favors by just leaving the darn thing closed. And then here, this is a bad outcome, is that in expanding the stent with the balloon, you have caused a dissection in the wall of the vessel, and that is a tear in the intimate itself. And so it has come away, right? And is sitting there as a flap of skin, and blood is going in behind it. And that's not good, right? So you probably want to put another stent in and get rid of that, right? And so these are things you can detect post procedure. And how you make the decision whether or not you're going to put one of these in to check is something that I can't tell you. There's probably a checklist like, oh, we had to inflate to this pressure. That is a risk, right? Let's go in and make sure everything's good. If the pressure was really high, right, et cetera, et cetera. So, okay, that's it. And so those are the ultrasound applications. We will start on Tuesday with, I believe, a review of MRI. Is that what's on the schedule, right? And at least 2 presentations. And so I'll send out the schedule.